All right, let's take a deep dive into this case of small bowel polyps seen on the barium follow-through examination. We've got a pair of spot images here, and the first thing that catches my eye are these filling defects, about 1 to 2 centimeters in size. They have this multinodular, cauliflower-like appearance. That surface texture, well, that immediately raises suspicion. This isn't the smooth contour you'd expect to see with something benign like food debris or a hyperplastic polyp. We're talking about something more structured. Looking closer, the larger lesion is in the terminal ileum, and the barium study clearly shows the defects. The patient's history is going to be key here, but based on imaging alone, I'm already thinking of something along the lines of Peutz-Jeghers syndrome, which, as you know, is associated with these hamartomatous polyps in the gastrointestinal tract. But let's not jump to conclusions just yet. We always have to consider a broader differential. What else could be causing these findings? Well, adenomas are on the list when we see bowel polyps, especially if the patient has a history of familial polyposis syndromes. Adenomas, unlike hamartomas, have a higher malignant potential. But what argues against adenomas here is the overall appearance. Adenomas tend to be smoother, solitary in many cases, and don't have that classic lobulated texture we're seeing here. Another possibility would be hyperplastic polyps. These are usually incidental findings, and they don't tend to cause symptoms or be associated with malignancy. But given the multinodular surface and the size of these polyps, I'd say hyperplastic polyps are unlikely. Also, we have to think about hamartomas here. They fit the size, shape, and texture, especially in the context of something like Peutz-Jeghers. Now, what about gastrointestinal stromal tumors, or GISTs? These can present as small bowel masses, but typically they're more focal. They wouldn't present as multiple polyps like we're seeing in this case. And on barium imaging, GISTs tend to show a different enhancement pattern compared to these polyps. So let's talk about Peutz-Jeghers syndrome. This is a genetic condition, inherited in an autosomal dominant fashion, and it's characterized by the development of multiple hamartomatous polyps throughout the GI tract, most commonly in the small bowel. But that's not all. There's also a striking extraintestinal feature, mucocutaneous pigmentation, often around the lips and inside the mouth. If you've got a history of GI polyps combined with those classic pigmented spots, it's almost pathognomonic for Peutz-Jeghers. But keep in mind, we can't just rely on imaging alone here. Another key aspect of Peutz-Jeghers is its association with complications. These polyps can act as a lead point for intussusception, which can be life-threatening if not treated promptly. In fact, on imaging, we would look for the classic target sign or sausage sign on ultrasound or CT, indicating the bowel telescoping into itself. Intussusception is particularly common in the small bowel in these patients. On these images, though, we don't see any signs of obstruction or intussusception. That's a good thing, but it also means we need to remain vigilant in future follow-up imaging. A CT or MRI might be indicated next, just to confirm the extent of the disease and to look for any potential complications. Now, stepping back for a moment, why isn't this something more benign? We've got these multiple polyps that are scattered throughout the small bowel, not just confined to one area. If this were an isolated adenoma or hyperplastic polyp, we wouldn't expect to see this distribution. Plus, the history and clinical findings would likely push us toward a familial syndrome like Peutz-Jeghers. So where does that leave us? Given the appearance of the polyps, the multinodular surface, their distribution, and the potential family history of gastrointestinal polyps, Peutz-Jeghers seems to be the most likely diagnosis here. But to secure that diagnosis, we'd want to check for that characteristic pigmentation, ask about a family history, and maybe even perform an endoscopic biopsy of one of these polyps. If we can confirm the histology, we'll have our answer. But don't forget, it's important to rule out malignancy. Although hamartomas themselves aren't malignant, patients with Peutz-Jeghers are at an increased risk of gastrointestinal cancers, so this patient is definitely going to need surveillance and regular follow-up. All right, let's anticipate some questions that could come up. For instance, how do you distinguish hamartomatous polyps from adenomas on imaging alone? Adenomas tend to have a smoother contour, whereas hamartomas, particularly in Peutz-Jeghers, have that characteristic multinodular surface. Another question could be, what imaging modality would you use next? I'd go for CT or MRI enterography to get a more detailed look at the polyps, assess for complications like intussusception, and plan the next steps for treatment. One more question you might be asked is, how do we manage these patients? Well, endoscopic surveillance is key. We want to catch any signs of malignancy early. And if the polyps are symptomatic, say, causing obstruction or significant bleeding, endoscopic or surgical removal would be necessary. So, to wrap this up, we've got a case of multiple small bowel polyps, likely associated with Peutz-Jeghers syndrome. The barium study has given us some great clues, and next we'd want to confirm with a detailed history, look for characteristic pigmentation, and follow up with cross-sectional imaging. If you have any questions, feel free to ask. Thanks for watching, and remember, stay tuned for more radiology cases. Don't forget to subscribe to Radiology Made Easy for more quick, focused radiological knowledge that's easy to digest. See you next time.